not only oral surgeons, but even for other departments where implants are carried out, especially periodontology and prosthodontics. It's very good that, and that too a topic I think is less known to people on basal implants. So in fact, initially I got confused that with basic implants, but then I realized it is about basal implantology, and we are extremely glad, privileged, and honored to have a eminent speaker, Dr. Gagandeep Gauba, okay, I think who has been extensively lecturing all over Malaysia, UAE, and so forth, and to have him as our guest speaker today. Thank you so much, sir, for accepting our invitation and to enlighten our students. Thank you.
Thank you so much.
So I'm sure all the PG students will definitely be enriched after today's lecture by Dr. Gagandeep Gauba. Thank you.
Thank you, sir.
Thank you, sir.
Now I would request Dr. Naveen Sir to say a few words. Good morning to all of you, all present. Good morning to our Dean Sir. Good morning to our eminent speaker, Dr. Gagandeep. The selection of the today's topic, the basal implantology, is a new answer to the implantology department where the bone is deficient, where different challenges are there, and how to find the solution, when to do the basal implantology, how to do it, what are the prerequisites, what are the challenges in the placement of basal implantology. All these things will be very well discussed by our eminent speaker, Dr. Gagandeep, who has got a good expertise in the field of basal implantology, and that will help us in decision making, in selection of a case, selection of different types of even basal implantology, and all those troubleshooting with challenges in the field of implantology. Osteosynthesis and osseointegration is a skill of an oral and maxillofacial surgeon. So basal implantology also will be a good tool for all of us to meet the patient's requirement in the future. So I welcome you, sir, for your expertise in this field, and will be enlightened by your expertise. Thank you, sir.
Thank you, sir.
Now the webinar is going to be led by Dr. Gagandeep Gauba, a renowned oral implantologist with a passion for education. Dr. Gauba expertise, commitment to advance in dental education, ensure that participants gain from knowledge and skills. Let's join this webinar for transformative journey in dental education.
Shall I begin now, sir?
Yes, sir.
So, hi everyone. Good morning. I am Dr. Gagandeep S Gauba, and the topic of today is basal implantology, the fundamental pillars. Okay, so I want to tell you one thing, that basal implantology is a vast science. Okay, and today is just the first step. As the famous Chinese philosopher Lao Tzu said, the journey of 1,000 miles began with a single step. Okay, can we please point to my face camera? I I think I have to continue this way. So let me tell you, basal implantology is a very vast science, okay? And the fundamental of basal implantology are very, very different of how we do the things in the conventional implantology. And understanding these, the underlying pillars, the very fundamentals, how was the basal implantology first incepted, is very crucial in success of basal implantology. I been wanting for so long to hold a webinar for PG students, because when I hold the webinar, mostly the participants are the private practitioners. Okay, so and training them on these principles they don't want. They want just give us the practical skills, and we just go to the clinic and start performing these surgeries on the patients immediately. They are not very much interested in underlying how does the basal implantology functions, right? So we will now begin. So, what is basal implantology? Basically, the basal implantology is, let me just switch on my highlighter. Right. So, what is basal implantology? Basal implantology is the application of the principles of orthopedic surgery and traumatology in the oral cavity for the rehabilitation and restoration of a failing or lost dentition. Okay, so what does happen is we embed the implant. These are known as surgical post into the basal cortical bone, and these are then used to retain and support the dental prosthesis, right? So we know now is that basal implant have a orthopedic parentage. We know that the orthopedic parentage of basal implantology. Basal implantology is often considered as the oral division of the orthopedic surgery, right? Why? Because it focuses on leveraging the basal bone, which is highly dense and less prone to resorption, to provide stable and durable implant solutions. So we have been talking now for quite a while about basal cortical implants, the advantages of basal cortical implants, but we must first understand what is the basal bone. So let me tell you very simply, when the tooth is extracted, okay, the tooth is embedded in the alveolar bone, right? So when the tooth is extracted, what happens is the residual ridge resorption takes place this way. Okay, we have all seen this diagram in our prosthodontic textbook. So what happens is the ridge resorption takes place, and whatever is left after the whole of the ridge is resorbed is the basal bone, right? Whatever is left after, we will also consider the definition. Basal bone is a dense stable bone that remains after the alveolar bone undergoes resorption following the loss of teeth. So basal bone basically forms the base of the alveolar bone. This is the foundation of the base of the alveolar bone, right? On this is the bone on which the alveolar bones rest, and all the loads and forces that are transmitted to the teeth and to the alveolar bone are ultimately borne by the basal bone. So in basal implantology, what we do is we place the implant in basal bone. We take the anchorage from basal bone, not from the alveolar bone. Right. So in this OPG, we can appreciate the various basal cortices that are present in our jaws. Let me refine the diagram here. So this is the same diagram. Okay, so there are various basal cortexes that can be anchored for our basal implants. In maxilla, we have the first one is a nasal cortical floor, right? In the premaxilla region, the nasal cortical floor is present. So what we can do is, in the anterior region, if we have to place the implant, we can anchor our implants in the nasal cortical floor. When we go distally to the premaxilla, what we see is we have the anterior wall of the maxillary air sinus, right? After that, we have the floor of the maxillary air sinus, then distal wall of the maxillary air sinus. Okay, we have considered these, right? In mandible also, we have the base of the mandible, right? We have the base of the mandible. We have the lingual cortical on the lingual side that we can engage, and the interforaminal region. This region has a very dense bone, the symphysis region, and this can be considered as a basal bone, right? We have all seen in even very resorbed ridges, even very resorbed cases, the the base of the mandible is still always present. So we can anchor the basal implants in whatever bone is left. We don't need very much bone for basal implantology. Apart from these conventional maxillary and mandibular cortexes, nowadays we are also considering placing the implant in extramaxillary cortexes. There are two primary extramaxillary cortexes. First is a pterygoid, right, and second is the zygomatic. Apart from that, in maxillectomy patients, we can also place the implant in glabella, right. Glabellar implants are also being popularized nowadays, and Dr. Vivek Gaur is one of the eminent surgeons, and he has done quite a promising work in this area, right. So we will move on to the next slide now. The rationale of basal implantology, how the basal implantology's idea originated. So it's very crucial to understand how the basal implantology evolved, because I just have, like I've told, that basal implantology's fundamental principles are very different from the conventional implantology, right? And understanding these principles is very important. The topic we are going to discuss, some will find it a little bit boring and dry, but it's very important to understand these principles, because if you don't follow the principles accurately, there is a huge chance of we are bound to that the basal implants will fail. Okay, basal implants are very easy to do, but are also at the same time very technique specific. Okay, the technique has to be properly followed, right? We are going to the next slide. So how does the basal implantology's idea originated? The basal implantology, like I told you, has the roots in the orthopedic and traumatology. Okay, right. So what happened was, while the orthopedic surgery and traumatology has long ago discovered a secret of safe and immediate loading, as the secondary surgical approach is often unfeasible and undesirable. Why? Because in traumatology, like we do in the extraoral procedures, if we have to do mandibular procedures extraorally, okay, we have to place an incision, we have to retract and dissect a lot of tissues, we have to take care of lot of vessels and nerves, right? And doing these kind of procedures in a two-stage surgery is often undesirable. Why? Because every time we put the incision and retract the tissue, we dissect the tissue, there is always a burden of swelling, infections and other post-operative things that can happen, and that can disorient the prognosis of the patient. So when we have to do the complex procedure, we always try that we do it in one approach only, not in a secondary approach. But meanwhile, in dentistry, the conventional dental implantology, it developed independently of the fields of orthopedic and traumatology. In dental implantology, dentists were always focused on the healing time, the implant surface treatments, the bone augmentation procedures. But after so long, the conventional implants are being done. We know now that these things don't have very much effect. Like there are certain studies that you can see in a comparison of rough surface and smooth surface implants. The difference between success rate is clinically insignificant, and by treating the implant surfaces, we are making the implants prone to peri-implantitis, right? What was initially, when the Brandmark invented implants, the implants were only smooth surface implants, and there was no peri-implantitis. And when we started treating our implant surfaces in lieu that the healing times will be reduced, we invented another disease, peri-implantitis. In traumatology, surface treating the implants is unknown, is unheard of. We don't surface treat the implants. Why? Because smooth surface implants are less prone to infections, are more safer for the patients. Okay, so here we can see this is a typical case of a fractured tibia. We have all seen x-rays like this. So what is happening here is there is a fracture line in the proximal tibia, and what the surgeon has done, surgeon has inserted a plate, and the plate is being stabilized by the screws on the both ends of the fracture segment. This is similarly like we do in the mandible, right? And now we will see a typical case that has been done in the basal implantology, right? So what has been done here, these are the basal implants that has been anchored in the basal cortical bone, like we have seen in the previous slide. This is the nasal cortical Okay, these implants are engaging the nasal corticals, and these implants are the pterygoid implants. I have these. There are two pterygoids placed here. Right, we can appreciate it. Now we will see both these radiographs side by side. I am really sure you must be all be able to see the striking similarities between both these radiographs. Here, what we see is the osteosynthesis system. It is also called as a BIB system, bone implant and bone system. Right, what is happening here is the fracture, the implants are holding the bone on both sides of the fracture segments, and the plate is splinting these segments. So all the burden will be borne by the plate. Similarly, what we see here in the basal implants, this is known as a BIPS, or a bone implant prosthesis system. So what happens is the implants are anchored in the basal bone, these hold, and the prosthesis splint. Like here, the plate is splinting, here, the prosthesis are splinting. Right, so we know now that how the basal implants idea originated from the orthopedics. Right, now we will be learning about mechanism of permanent biological integration of basal cortical implants, that how these basal cortical implants are anchored in the bone, because this concept is very different from osseointegration. In osseointegration, we place the implant, then we wait for 3 to 6 months for the implant to integrate the bone to heal around the implant. But in basal implantology, the fundamentals are entirely different. Right, so these fundamentals are, the principles are osseofixation, the osseoadaptation, and the osseointegration. So what is osseofixation? Osseofixation is the direct cortical engagement of the implant by the surgeon at the time of surgery with high primary stability. Okay, direct cortical engagement of the implant by the surgeon at the time of surgery with high primary stability, and is capable of immediate functional loading without the need of any further osseointegration. We must emphasize in this point that osseointegration is not at all required for the functioning of our implant. The implant is directly anchored in the basal cortex by the surgeon at the time of surgery. If done properly and the implants are splinted properly, the osseointegration of the smooth surface will take place, but it is not necessary for the functioning of the implant. Can we please switch on to the tabletop?
Done, sir.
My tabletop is visible. Can we make it the main screen? Can you please make it the main screen?
So you have to stop sharing your main PPT.
Okay, right. I think the tabletop is still not visible. It's facing my face camera.
So you'll need to share the tabletop screen as well.
Need to share the tabletop screen. No, I am not able to do that. The option is not coming on my end. It's visible.
Yes, sir. Yes, sir. It's done.
Right. So we must understand the concept before I demonstrate the nasal cortical engagement. We must understand the concept of R1, D1, R2, D2. Okay. So we will put this aside for now and focus on this. So the concept is R1, D1, R2, D2. Okay, so when I'm placing my basal cortical implant, what I will be doing is I will be first entering the soft tissue because basal implants are done flaplessly. Okay, and when I hit the bone and I start turning my drill, what I will feel is I will feel a resistance. Okay, and when I perforate the first cortex, okay, when I perforate the first cortex, what I will see is the drop. There will be a drop because I will be entering a soft bone. Again, when I will be approaching the nasal cortical floor, again I will feel a resistance. This is the R2 resistance. Okay, when I perforate it further, there will again be a drop, and my drill will enter in the I will bypass the nasal cortical floor. Okay, my drill has passed from the nasal cortical floor. So this is the concept of R1, D1, R2, D2. This is very important to when we are doing the surgery. Okay, now I will take the implant and will start inserting it in the osteotomy site with my hand driver. And when my implant will reach the nasal cortex, everyone will be able to appreciate the implant has perforated and engaged the nasal cortical bone. Okay, this is the osteofixation. I have placed the implant and anchored the threads in the basal cortex. So this is how the osteofixation is done. Okay. Now I will come back to the presentation once again. Right. I hope everybody will be able to see the presentation. So I have demonstrated how the nasal cortical anchorage is done. We can also see it on the IOPA. How does it look when we place the implant? This is the nasal cortex. Okay, the implant has engaged the nasal cortex, and this, if we have a CBCT done post-operatively, this is how we will see the basal implant in the CBCT. Right. Now we are going to the next slide, the Wolff's law. Okay, one of the other fundamental pillars of basal implantology is the Wolff's law. So what does the Wolff's law states? It states that the bone in a healthy person or animal will adapt to the loads under which it is placed, and the osteoadaptation is the implication or application of the Wolff's law in our basal implantology. So what does we get from the Wolff's law? That the bone in a healthy person will adapt to the loads under which it is placed. So when we place the implants through osteofixation and we load the implant, the remodeling, the continuous functional loads that we apply on the implant will remodel the bone, and the bone will adapt over the surface of the implant. Over the period, due to continuous stimulation of the bone multicellular units, the bone will densified. The bone will be very dense. There will be D1 type of bone that will be formed around the implant, and that will support the implant and throughout the life of the implant, and that is what leads to the long-term stability of our basal implants. Okay, now we'll be continuing to the principles of the basal implantology. These are the various principles of the basal implantology. There are certain orthopedic derivatives and there are some dental modifications of these orthopedic derivatives. So we will go through these one by one. First is the selection of the implant according to the situation of the bone. Right. So what we'll do, we select, there are numerous type of basal implants available. There are mostly 5 to 6 types. Okay, and we will select the implants according to the bone present, both in quality and both in quantity. We will not modify the bone to fit the implant. We will be not be doing any alveoplasties. We will not be doing any bone grafting. That is why, because of this thing, we don't have to do alveoplasty, we don't have to do bone grafting. in dental modification, we do the procedure flaplessly. We don't have to raise the full thickness mucoperiosteal flap. The second principle is basal cortically anchored implant. Like I have shown you in the tabletop demonstrations, the implants have to be anchored in the basal cortex, right? And the machine surface implants, the ad modem brandmark surface. Initially, the implants were only smooth surface implants. The rough surface we did to achieve quicker healing times of the implants in the bone. But in basal implantology, we always go with machine surface implants, machine surface, a smooth surface. There is one implant. This is an exception to this rule, and I will be demonstrating to you in the later slides. Another principle is compulsory immediate loading and compulsory immediate splinting. All the basal implants have to be immediately loaded and immediately splinted within 72 hours before the beginning of bone remodeling phase. Right. And what are the various dental modification that we did is first is the no prosthetic connection. There is a monoblock construction. The implant is, one second, the implant is entirely made of a monoblock construction. There are no prosthetic connections. This is a single piece implant. We do the surgeries flaplessly. There is no need in basal implantology to open a full thickness mucoperiosteal flap. And no osseous corrective surgery. There is no grafting involved. There is no alveoplasty involved. There is also the concept of biological respect area. We will be studying this in the following slides. Also in the prosthesis, we do two things. There is no cantilever in the prosthesis. There is always the distal implant present. Like shown you in the radiograph of the basal implants, in the distal segment, I have placed a pterygoid implants to avoid the cantilever. Right, and the implants with a reduced emergence profile, we will also be studying that. And the free placement of abutment, the basal implants are bendable. Since there is no prosthetic connections, the implant is a single piece. To correct the angulation defects, the implant can be easily bent and brought into prosthetically desirable position. And the prostheses we give are always hygienic prostheses. The intaglio surface is concave, not convex, so it deflects food. If there is in food lodgement, and is easily cleansable for the patient, right? So we will be moving for the to the first principle, that is selection of the implant according to the situation. So I have, just like I told you, there is no bone grafting concept in basal implantology. Why? Because bone grafting is unpredictable, expensive. There is a need of second stage surgery, and it also adds to the cost of the patient. We have heard many times that when bone grafts come in, the predictably goes out of the equation. Whenever you place the bone graft, the situation becomes unpredictable because you are totally relying on the acceptance of the bone graft by the patient's body. At that point, the ball is not in your court. The ball is in the biology's court. The biology may accept the graft. The biology may reject the graft, and if the graft is rejected, the implant automatically fails. Right. So in basal implantology, we have various implant designs to accommodate the type of bone present. So there is a classification that I have made, right? So we will be studying that, and later in the next slide we will be seeing how these implants looks like. Okay, the classification is the basal implants. If you classify, there are two broad categories of basal implants. First is a partially threaded implants. These are the basal cortical screws, and second is the fully threaded implants. These are also known as compressive implants. Right, so there are three kind of implants in the partially threaded variety. This is the basal classic, the basal varios, and the basal vampire. These are the three kinds of partially threaded implants that are present in our catalog. These implants have different usages in different case scenarios, and we will be studying these in the later slides. And in the compressive side, when we see, we have two implant designs. One is the basal tornado and one is the basal pros. Right, this is the basal pros. This is the only rough surface basal implant that is present. Right, the use case will be also studied in the later slides. So now we will be studying these implants one by one. The first we will be studying the partially threaded implants, the basal cortical screws. Okay, this is also the Bahubali of dental implants. Let me tell you, this implant is such a wonderful implant device that the basal implantologists have invented. The it can be done in almost every case, whether there is bone available in width or not, every bone quality, every kind of situation. When the in fact in the mandible, when there is residual resorption is still the mandibular nerve, in that case also this implant can be easily placed. We will be seeing this in the following slides. Okay, so the basal cortical screws, like I've told you, there are three designs present. First is the basal classic, the basal various, and basal vampire. The use case is similar, the procedure is similar, the protocol is totally similar. What does difference is there is different is in the threading profile. Okay, the classic design is for D0, D1 bone, the very dense bone. We use the basal classic. When the bone quality is of D2 to D4, we can use the basal various. And if we have very osteoporotic bone, very osteoporotic bone like D5, D4, D5 bone, then we go for the vampire implant. Okay, the thread profiles on these implants are very different, and these implants provide increasing order of anchorage as we go from this implant to this implant. As we can see in the threads, this is the cortical threads are present in the classic implant, and in the various design there are cortical implants as well as the cortico-compressive implants are present. These in addition to cortically engaging the implant, when the bone density is very less, these provide lateral compression to the bone, which will then osteodensify the bone in this region and increase the anchorage. And in the vampire design, we have Whitworth threads. They are a dual thread design. There are two threads that are running in the implant, and these provide double the anchorage. Like in the normal, what the classic implant provides, the anchorage of vampire is approximately double that. So in very less dense bone, we will use the vampire implant. Okay, and now we will be seeing the distinguishing features of the basal implant. This is the basal cortical screw, and these are the sizes that are available. We can appreciate the diameter, the minimum diameter available is 3.6 and maximum diameter is 5.5. That is so normal. In conventional implantology, we also have such diameters, but when you come to the length, you will see the length is minimum of 10 millimeter and up to 29 millimeters. This is a very distinguishing feature of basal implants because we are engaging the basal cortical bone that sometimes will be very deep to the first cortex, so the length of the implant required is very high. Second distinguishing feature is it's a single piece design. There is no prosthetic connections. The implant is totally made from one piece of titanium, right? And other is a smooth surface. The implant is of smooth surface design. There is no polish, there is no surface treatment done in basal implant, and the threads are only at the apex. That is why these are a partially threaded design. The thread of the implants are only at the apex. Why so? We will see in the following slides. First we will come to the smooth surface. The implants are whole sole made up of polished machine surface titanium. So what are the advantages? The advantages are there is no risk of peri-implantitis because of smooth surface. Even there is some bone loss is there, the exposed surface will be smooth and it will be self-cleansing. So there will not be any kind of peri-implantitis. Because of smooth surface, the implants can be done in diabetics also, right? The implants can be done in smokers also. Because basal implants, we engage the implant through osteofixation, and in diabetic and smokers what is happening is the healing of the body becomes a little bit slower, it becomes delayed. So osseointegration is not able to take place. Because osseointegration, we totally rely on the biology once again, right? In basal implantology, we bypass the biology. In conventional implantology, when we want the osseointegration to happen, we have to wait. But in diabetics and smokers, the osseointegration still might not happen even after waiting for 6 months, and may lead to very painful failures for the patient also. The basal implantology, because of the partially threaded design, right, we can do in immediately after extraction, and even in the case of periodontally infected teeth. Because of the smooth surface, there is no chance that the infection will be carried forward towards the basal bone. In rough surface, when we pass the implant through the infected site, what will happen is we will take the infection, the pus, everything that is there, and these will all be transported towards the apex and towards the bone in which we are fixing our implants. But because of the, as a virtue of the smooth surface, the implants can be done in infected sockets also. Both in extraction and delayed cases, the reintegration of the implant is possible even if the implant is failed, because of some technical errors we have not breached the second cortex and we have not engaged second cortex properly, and the implant fails. The same implant, we can remove it and we can place after doing the performing then correcting the osteotomy. And also, even in the case of failures, we can remove and replace the implant with a wider or lengthier implant if that is needed. A very important note is the superpower of the basal implant lies in the shaft or neck and its monoblock construction. Now you will ask, a superpower, how can an implant have a superpower? So let me explain you. This shaft of the basal implant, the shaft is from the uppermost thread to the base of the abutment. This is the shaft of the implant. So the shaft of the implant is only 2 to 2.5 millimeter in diameter, and it's made up of polished surface, it's not surface treated. Then that because of this, the intraosseous placement and positioning and presence is not required. This shaft does not need to be inside the bone at all. This can be anywhere in the soft tissue. And also, because of the narrow diameter of the shaft, the implant can also be bent. So these are the two very important practical applications and I will say achievements of basal implants. Because of the shaft, we are able to bend the implant, right? We can place the implant anywhere the bone is present, and we don't have to worry about the prosthetic position, because we can bend the implant to achieve parallelization for prosthetic rehab. In conventional implants, we have seen a lot of cases. What happens is there is bone available, but the angulation of the bone, if we place the implant in that bone, the angulation is not prosthetically desirable, and we have to go through a lot of headache to prosthetically rehabilitate the patients. The oral surgery department might have seen a lot of discrepancies with the prosthodontic department over this thing, that when we place the implant in the available bone, the prosthetic rehabilitation becomes very difficult, and we have to go for custom milled abutment or casted abutments. But in basal implantology, this problem is not present at all, because we can place the implant any position we like, just engaging the basal cortex and then bend the implant to bring it in the prosthetically correct position. Like we can also see in this radiograph, there is a very thin knife edge ridge present. As you might be able to appreciate, the ridge present is very narrow. So in basal implant, what we do is, instead of doing the osteoplasty and then going to this bone, we directly bypass the alveolar bone. This is the alveolar bypass technique. What we do is, we start the osteotomy on the palatal aspect and then engaging the basal cortical bone. The shaft is present freely in the soft tissue, so there is no problem this creates in basal implantology. In conventional implantology, if the implant is exposed, the implant will fail, but in basal implantology, this kind of failure is not seen. So this is a superpower of the basal implantology. And because of this virtue, that the crestal position is not required, we can go with the flapless placement technique. The basal implants can be inserted without raising a full thickness mucoperiosteal flap. Why? Because crestal entry of osteotomy is absolutely not necessary. The only focus in basal implantology is that the threaded portion, the apical portion, the few millimeters on which there is thread present, that should be engaged in the basal cortex. If that is happening, the implant is okay. The remaining implant, if that is not even in the bone, there is no problem with that. There is also again a very important note, that the diameter of basal implant is decided on the basis of the quality of the bone Okay, the diameter of the basal implantology, we mostly follow single drill protocol. We do the osteotomy. When we do the osteotomy, through the tactile sense, we feel that what kind of bone is there. If there is a very dense type of bone, we use a narrow diameter implant. We use a 3.6 diameter implant. If the bone density is very less, there is a D5 type of bone, the diameter of implant we use is 5.5 mm, right? And it's a philosophy of basal implant that it's better to have more bone around the implant than a wider implant and less bone around it. Right, so we move on to the next slide. Because of flapless surgery, there is another advantage, like this journal shows. In the flapless surgery, when we go for flapless surgery, it demonstrates very less crestal bone loss as compared to flap surgery. The periodontal department will knowing this very adequately, that whenever we open a flap, there will always be certain bone loss present, whether we do any surgery or not. Even if we raise the flap and close it up, there will be bone loss, because we do the surgery flaplessly in basal implantology. There is very less chance of having this crestal bone loss in basal implantology. The other principle is the free placement of the abutment and parallelism by bending. I have compiled two principles in this slide. So we can see is replacing the second molar, replacing first molar, on the apical end, the sinus is pneumatized till the first premolar. We have seen these situations very commonly, that the bone is not present when we want to place the implant. In such situations, we have to go for sinus lifts in conventional implantology. Whereas in basal implantology, what we do is we anchor the nasal cortical above the canine, right? This is called the canine bypass technique. And because the prosthetic, the implant abutment will come this way, then what we can do is we can bend the abutment, bend the implant, and bring it to the prosthetically desirable position. Also, in the mandibular segment, there is a technique of lingual cortical engagement. In basal implantology, if vertical height is not present, okay, even if 6 mm vertical height is present, what we do is we anchor the implant in the lingual cortical just below the mylohyoid ridge. And because the implant will come in this direction, we can bend the implant and bring it to the prosthetically correct position. Now I will again demonstrate you the placement of the implant, like I have shown you. Right. So I will be demonstrating the bending of the implant and also the placement of the lingual cortical engagement implant. So if vertical bone height is not present, what we will do, we will engage the lingual cortical. Where will we be engaging the basal cortical? We will be engaging just below the mylohyoid ridge. We can appreciate this black line. This marks the mylohyoid ridge. This is the attachment point of the mylohyoid muscle, right? And what we will doing is, when we will placing the implant, we will place a finger just below the mylohyoid ridge, and we will begin the osteotomy from the buccal aspect in a tilted position. And what will happen is, we will feel a resistance, then a drop, then a resistance again, and then we will feel the tip of the implant coming out on the lingual side. We can appreciate the tip of the drill is coming out on the lingual aspect. Okay, when we palpate this, we will stop drilling, we will not drill any further. After that, what we will be doing is adequate length implant we will choose. So this is the 3.6 mm implant, and I'm opening the implant packaging now. These are the various prosthetic components that comes with the implants. And because it's a smooth surface implant, we can directly hold the implant with our gloved hand. It's not the rule that we can't hold the implant. Because of the smooth surface, we can hold the screw in our hand, then we will engage it in the hand driver, we will be seeing this. Right after that, I will be placing the implant in the prepared osteotomy site. Now we can see the implant has come out on the lingual aspect. Now the lingual cortical engagement is complete. My implant have engaged the lingual cortex, and everyone will be able to appreciate the prosthetic position. It's not at all desirable. It's not desirable. You can't place the teeth in this position. So what we can do is we can bend the implant. Bending is very simple. We will engage the implant, and then towards the prosthetically correct position we will bend the implant, and now we can see the implant has come in a prosthetically desirable position, and the implant has not fractured. The implant can be bent up to 45, even 50 degrees in certain cases. There is also implant done in the previous presentation that I did. This is still present in the model. Okay, so we can all appreciate that how the basal implant is placed and bent to bring it in the prosthetically correct position. So we can, as we have now shown, that because the vertical height was very less because of the resorption, what I have done is I have engaged the lingual cortex, right, without touching the inferior alveolar nerve, and bent the implant to bring it into a desirable position. We have seen this. And we will come to the other principle of the basal implantology. This is the no need of osseous corrective surgery. In basal implantology, there is no concept of osteoplasty or bone grafting. Even in the immediate extraction implant placement, we don't graft the bone. But how? Because of the smooth surface, right? Even when we place the implant in the fresh extraction socket engaging the secondary cortexes, the exposed surface is the smooth surface of the implant. If there is a bone growth on this surface, it's very good. Even if there is resorption, like we have seen when we extracted tooth, there is a crestal resorption. Even this, when this happens, the shaft is smooth surface and will be only in contact with a soft tissue, so there is no problem in that. And in the knife edge ridge, as we can see, we go with the alveolar bypass technique, like I have shown you in the previous slide. What we will be doing is we will be placing the implant slightly labially and engaging the basal cortex without going through the crestal osteotomy, because in the crestal implants or the conventional implants, the implants has to always be placed through the crestal position to bring it in the prosthetically ideal position. So in this case, if I had to place a conventional implant, I had to lose all this bone. This vertical bone height has to be lost, then I will place the implant. But in basal implantology, it is not required. This is also another case, like in the maxillary molar extraction sites, we can place two implants, one in the palatal socket and other in the mesobuccal or distobuccal root socket, and these implants function very well, engaging the floor of the maxillary air sinus. So this is the cortex that these implants are engaging. Right, we can all appreciate it. And I will now again demonstrate a case of such a thing. Right, so here we will see there is a extraction site on this model. We can clearly see there is a extraction site present, and just wait on a minute. We can appreciate that there is a buccal wall defect. Right, there is a buccal wall defect is present. Right, when we are, if we are to place a conventional implant this side, what we'll do, we have to graft this area to cover all the threads, because if the thread remains exposed, there will be peri-implantitis and there will be the loss of the implant. But in basal cortical dentistry, we will place the implant after doing the required osteotomy. We will place the implant in this site, and what we will see is the only exposed area we see is the smooth surface, right? So what will happen is, if there is bone healing is there, then it's very good. Even if the bone does not heal on this side, there will be soft tissue integration of the implant shaft with the mucosa present here. Like we have seen in the oral surgery plates, the external surface of the plate always lie in the intimate contact with the soft tissue that is present over here. And in certain cases, when we have to remove these plates, we have seen the tissue is totally integrated with the plate adhesion is there, right? We have all seen that. And similarly in this case also, because this is smooth surface titanium, the soft tissue will adhere because of the hemidesmosomal connections, and there will be muco integration of the shaft in the soft tissues. We're saying no need of osseous corrective surgery. Okay, we have seen the demo of buccal wall defect. Now we will move on to the next slide, that is the area of biological respect. This is a very crucial aspect of the basal implants. So the area of the basal implant that lies between the topmost thread and the base of the abutment, the shaft of the basal implant, the smooth polished shaft that we have talked about, that can be bent, is the area of biological respect. Why it's called the area of biological respect? Because in this case we can appreciate the vertical bone has totally resolved. Okay, there is no vertical bone height present above the inferior alveolar nerve, so we can't place the implant. Also, because there is no height present, we can't go for lingual cortical engagement in this case. In this case, in these kind of situation, the basal implantologist still has an answer without going for the bone grafting. The answer is the inferior alveolar nerve bypass technique. These can be done both on the buccal aspect as well as a lingual aspect by considering the place of the position of the inferior alveolar nerve in the bone, right? We can see that this area is lying very near to the inferior alveolar nerve. So in basal implantology, this is the area of biological respect. Why so? Because this area does not have any threads and is of smooth surface and of very narrow diameter. So even if we place it near to the very crucial structures like nerves or even in the sinuses, there is no chance that the anatomical structure will be damaged. After the placement of the implant, there is no thread, there will be no compression of the nerve will be there, right? The nerve will be totally unaffected even if we place the implant directly next to it. So that is why this is called the area of biological respect. Another important principle is the implant with the reduced emergence profile. The implant, I have told you, the shaft is very narrow diameter, right? So the area of the implant that is coming out from the osteotomy site will be only this shaft. So this diameter is very low, and it ensures the minimum irritation of the soft tissue. The soft tissue does not get irritated. Also, because of smooth surface, there is no food lodgement here. The patient can easily rinse and dislodge the food if it is present here. And also with water flosses and other modalities, the high maintenance of the hygiene in these implants is very easy. I think the lecture is taking a bit long, so I will skip this demonstration. We will move on to the next slides. As we have studied, there is no prosthetic connections. The implant is entirely made up of single piece monoblock construction. And what does the advantages that this monoblock design gives us? there are various advantages, because there is no screw loosening, there is no screw fracture, there is no implant fracture, there are no micro gaps at the implant abutment junction. Thus, the peri-implantitis does not happen, and because of this, there is no crestal bone loss. Also, apart from that, we can do the surgery in a single step, right? We don't have to wait for the next sitting to place the abutment and open the patient once again for the placing of abutment after the healing period is over. And there is also no concept of healing abutments in basal implantology. One abutment, one time concept, because the abutment is attached, the abutment is placed at the time of surgery only. And because of this, the muco-integration of this shaft takes place through hemidesmosomal connections. And this ensures that there is no flow of infections or saliva or other oral fluids to the implant surface after the healing is over. And also we can see in this paper, the implant abutment connection is always stood a gray area in the survival of the conventional implants, because if there is a connection present, whatever kind of connection that we use, even if we go for external hex or internal hex or conical connection, in every type of connection, the accuracy, with even with very high accuracy now, the micro gap is still present, and there will still be certain flow of the fluids. And if there is screw loosening, the micro gap enlarges, and again, due to the micro gap, the implant abutment junction, there will peri-implantitis and the implant will fail. And in basal implantology, we go for immediate functional loading. Why? Because the origin of, as I told you, the origin of basal implantology lies in the orthopedic and traumatology, right? In orthopedic and traumatology, it is well known that healing of the bone starts 3 days after any bone surgery or fracture, and in the first 3 days the bone healing is not started, right? So what we do in basal implantology, we immediate functional load the implant with our prosthesis. Why? Because if we load the prosthesis before the 72-hour mark, what will be happening is we will be stimulating the bone will be simulated, and because of the simulation, right, what will happen there will be osteoadaptation. Because of the Wolff's law, the bone will start adapting on the surface of the implant. And this is why, because of traumatological and orthopedic parentage, the implants have to be compulsorily loaded in basal implantology. This is not a function, this has to compulsorily done, right? This has to be done in every case. And immediate splinting. When we will be placing multiple basal implants, we will be splinting the implants either through prosthesis or through intraoral welding, right? If our prosthetic, like the department is the prosthesis, your prosthesis is fabricated in your laboratory in the college itself, right? So you can get your prosthesis early on, like you place the implant on the next day or even in the same day, you can fabricate your PFM prosthesis for the implants. But in private practice, because some people get their done from the other labs, they outsource the lab work. So in those cases, if there is certain delay, like you get the prosthesis in 4 or 5 days, what you can do is you can syncrystallize or intraoral weld the implant with the titanium wire, and later on when you get the prosthesis, you can remove this wire and place the prosthesis over the implant, right? Studying all these, we have also done the principles of basal implantology. It's a very important note that I like to present in front of the audience, that penetration and fixation of the implant in basal cortex is absolutely necessary for the success of the implant. The basal cortical screw needs to be actively engaging the basal cortex, right? If due to anatomical constraints, the penetration of the opposing cortex is not possible, desirable, or detrimental for the patient, other designs of the basal implantology should be present. In basal implantology, we also have answers to the situation in which we can't place the implants in the engaging a secondary cortex, right? Like in case of the inferior alveolar nerve, there are certain cases where we cannot engage the implant properly in the secondary cortex. Okay, in these cases, we have other modalities, other kind of implants are present. So the first one I will want to tell you is the basal tornado. This is the smooth surface, fully threaded implant, right? So what we can do is, these are for those situations in which the opposing penetration cannot, the opposing cortex cannot be penetrated and cannot be breached with our drill. Okay, we cannot perforate the opposing cortex, but this is a very important point, the implant apex can be rested on the basal cortex without actively engaging it. We can see in this radiograph, I have placed this implant. So what I have done is, because the patient has sinus issues, right? So if I tried to go for the basal cortical screw, there might be the trouble of infection of the implant because of the sinusitis issue, the sinus infection. So in this case, I will be using a smooth surface compressive implant. And what I have done is, I have rested the apex of the implant on the floor of the maxillary sinus, right? We can appreciate this. And there is also certain cases, even if we are not able to rest the apex of the implant on the secondary cortex, in that case we have a basal pros design. Basal pros is similar to the basal tornado. The only difference is that this is a smooth surface design, and in this case the surface of the threaded portion has been treated with SLA treatment. Okay, what we have been done, we have sandblasted the surface and then the acid at the surface, like we do in the conventional implantology. This is the exception. This implant, the surface treated implant, is an exception to the established norm of the surface characteristics in basal implantology, but it does not violate the principles of traumatology, because such kind of implant, the surface treated implants, are used in the polyaxial screw that we are using in the treatment of spinal fractures. The polyaxial screws, that the perforation of the secondary cortex is not at all desirable, right? Because there are certain vessels and nerves present on the medial side. Okay, and then what happens is, the engagement of the implant in second cortex is not at all possible. So this is why they also use a surface treated design. The practical application I will show you in this slide. We can see, because the nerve was there, right, and because enough vertical bone height was present, I chose not to engage the lingual cortex. What I have is done, I have placed a surface treated basal implant in these areas. So the mandibular area is a very good example of usage of the surface treated basal implants, right? I think that's enough for today. So we must end the presentation. So this is the topics for the coming webinars. In the coming webinars, we will be discussing about the pre-procedural protocols, the patient evaluation and education, the radiographic analysis, and the surgical planning on the radiograph. How many implants we will be placing, how we will be placing the implant, what will be the necessary angulation, right? And apart from that, we in the other webinar, we will studying the surgical protocols, the various surgical protocols that are present in the basal implantology, like the nasal cortical engagement of the sinus flow, the pterygoid implants, the basal zygomatic implants. After that, we will learn about the prosthetic protocols, because in basal implantology, the prosthetic protocol is just like a conventional FPD we do, but there are certain differences in the impression taking only. In impression taking part, the impression we go with the copings, right? And there is a little bit difference, so that I have to explain. Otherwise, the prosthesis is just like we fabricate a full mouth bridge or a single cap PFM for a FPD. Then we will be studying the maintenance protocols and troubleshooting, right? And I will be thanking Sumandeep Vidyapeeth and Bone Anchor Implants for providing the models and implants for this presentation. And this is my contact information. If there is any queries, you can contact me on this number. You can WhatsApp me or you can mail me, right? Is there any questions? I am open for questions now. I am stopping the screen sharing. Right. Am I visible?
Sir, you're visible.
Right. So are there any questions by the participants? You can unmute and ask the questions. No questions? No doubts?
Sir, one of the participant is asking that what is the difference between splinting and welding?
There's no difference. Basically, the splinting, what we do is we fabricate the prosthesis or a rigid bar, okay, for the implants in the lab, right? So there is a delayed procedure. We have to wait for some time for the bar or the prosthesis to come. Meanwhile, we can do is we can crystallize the implants with intraoral welding. Both do the same thing. Both do the splinting. Both distribute the load of the implant all the implants. So because of that, the load on single implant is reduced and it increases the prognosis of the case. Like in my practice, I have a laboratory in house, so I get my bar casted on the same day. On the next day I am able to place the splint. But in certain cases, if you are outsourcing the fabrication of the bar or the prosthesis, in that case we can go for splinting also through intraoral welding. Right? Any other question?
Thank you, sir. Sir, I would request Amit sir to come and give vote of thanks.
Yes, sir. Yes, ma'am.
I would like to thank Dr. Gagandeep for such an insightful information on the basics of basal implantology. It was a good introduction for the PGs as well as the persons who are now doing basal implantology. Thank you, Dr. Gagandeep. I would also like to thank everybody who has helped me out in conducting this webinar. The IT team, my PG students and the interns and everybody. I would like to thank my HOD sir for allowing us to conduct this. And I would also like to thank Dean sir for introducing us to you. And then we were able to do this webinar. Thank you very much. Looking forward for another series from you. Thank you.
Thank you.
Thank you.
The recording has stopped.